It's my pleasure to chair this session, and I wish to thank you for the invitation. Now, since the introduction is already done, I don't need to speak much again of myself. Thank you so much. The first presentation we will take is on a keynote on global partnerships to reduce the burden of neurotrauma, learning together to understand, to prevent, and to respond. And this topic is very important because neurotrauma is a global phenomenon and needs a global response. And we have two eminent professors who are cornerstones of neurosurgery in the world who give this talk, starting with Professor Figaji Anthony, who is a professor of pediatric neurosurgery in Cape Town University. He is a global leader for pediatric neurosurgery in Africa. And then he's lead actually the African Brain Child Initiative, which is a group of interdisciplinary professionals with the objective of improving outcomes of children with brain injuries through research, advocacy, and capacity building. And I must say, he's the first African to win the Welcome Award 2025. So we are glad to have Professor Figaji among us. And after his presentation will be next by Professor Peter Hutchinson, who is a professor of neurosurgery, University of Cambridge. He is a key knee principal investigator and honorary consultant for neurosurgery in the Addenbrooke Hospital. He heads the Knee Global Health Research Group for acquired brain and spine injury. Professor Hutchinson is a global leader in terms of acute brain research and is a winner of the Oliver Kroner prestigious award, and of course have authored or co-authored over 900 articles. So we are very pleased to have these two eminent professors present this keynote. So we'll be starting. Join me, welcome Professor Anthony Figaji. Hi, Anthony.
Well, thank you, Ken. Just confirm that you can see my slides.
Yeah,
fantastic.
I think I can see the slide. I hope everybody can.
Great, thank you so much. So thank you for the kind invitation. A few years ago, I remember having a conversation with a funder, or at least a representative of a funder, and they are a global funder. They funded a huge amount of research, mainly in infectious diseases, and a huge amount of that research is here in Africa. And I was asking them why they didn't fund injury research or neurotrauma research. And I was quite taken aback at their response, because they said that, well, infectious diseases kills more people than trauma. And after all, trauma is not a disease of poverty. And I was really shaken by that, what I thought was a lack of insight. And then after thinking about it for a while, I realized that maybe part of the problem is just a failure of communication about the actual burden of disease. And in reflecting on what they've done in infectious diseases, I came to the realization that part of the problem is that we don't have as good a data set, because we don't have our disease or the condition that we treat recognized as a registrable condition. And so I spoke about that at the ABSI launch in Cambridge, and that sparked a conversation with Tariq Khan, and that led to this building initiative that he has driven, and hopefully will manifest in a resolution that we're trying to get done at the World Health Assembly to make traumatic brain injury a registrable condition, because that's the only way that we can foresee us having the actual numbers, and one needs the numbers to be able to argue for the resources that we need. So the perspective is, and let me just tell you a little bit about the numbers that we do have. So neurotrauma is by far the commonest high-risk neurological condition that we see across the world, and particularly in young people. And I think it's worth focusing on young people, because when you look at global burden of statistics, it's often skewed by the cause of death of people in their 80s and even in their 90s. And of course, one has to always die of something. Very often it's going to be cardiovascular, always going to be Alzheimer's, always going to be cancer. But when you look at preventable conditions that affect young people in the prime of their life, it's injury. So For people aged 5 to 29 years, amazingly, 3 of the top 5 causes of death are injury related. And of those injuries, it's the injury to the head that is the single leading cause of death and disability across the world. And so when we looked at our statistics for children at our hospital, we have a large trauma burden. More than half of all deaths in injured children are due to the injury sustained by the head. And then if you look at this in comparison to other things that cause death in children, and in particular, where you compare it to the deaths due to tuberculosis, HIV, and brain tumors, because as neurosurgeons, we see brain tumors as well. You can see that head injury is much, much more common as a cause of death. And this doesn't even touch on the disability in the survivors. So just in terms of burden of disease, it blows these other big conditions out of the water, but somehow it doesn't translate into the global burden of disease that we read about very often, as published in the Lancet. And it really is the tale of two wolves, because the likelihood of dying or being disabled due to an injury is much less in high-income countries than in low and middle-income countries. And those resources one sees both on the clinical and at the academic side is very much skewed towards the global north, and in particular North America and Western Europe. The problem, of course, is that 90% of injury deaths occur in low and middle income countries. And when we looked at some of our statistics, you'll see, and I'll show you the graph of it, that children in South Africa are 8 times at higher risk of dying than similarly aged children in the UK, and more than 10 times at higher risk than a similarly aged child growing up in Switzerland. And so here you can see the likelihood of at least the mortality rate per 100,000 in South Africa from road traffic accidents compared to the United Kingdom and Sweden. And of course, the population is just extending in developing countries. So what I just showed you was a rate per 100,000. So you've got to take that rate per 100,000, and then you've got to multiply it by this expanding population in developing countries, because the birth rate, of course, is higher in developing countries. And then more important, or at least as important, our data collection is really, really poor. And it's actually not that bad for communicable diseases, infectious diseases. So the column on your left in red, that's communicable diseases. And what I've highlighted is the data availability, and it's the size of the dot that reflects the amount of data available for North America at the top and Western Sub-Saharan Africa at the bottom. And they don't look too different in terms of the data availability for infectious diseases, maternal diseases, neonatal and nutritional diseases. But when you look at injuries, so the top one again is North America, and the bottom one is Western Sub-Saharan Africa. There's a big difference, not only in the number of cases that you see, but the data that we have available to make the arguments that we need. So somebody may argue maybe we have all that we need to know about neurotrauma already, but that's not true, because our prevention programs haven't been very successful. We have a weak evidence base for the guidelines for therapies, especially for children and low and middle income countries. It's exceptionally difficult to get funding for neurotrauma clinical research. And in my experience, I've been so much more successful in getting funding for any infectious disease project than for neurotrauma. And importantly, we're only seeing what we here in the Southern Hemisphere call the ears of the hippo, that you may know better as the tip of the iceberg, because there are so many things that we're just not quantifying. That includes survivor disability in low and middle income countries, the need for rehabilitation in those survivors, the economic cost of disability for the family as well as for the community. And then we tend to focus on severe TBI, because that tends to be a surgical or a critical care condition, but 90% of TBI out there is mild TBI. And that burden largely is unquantified. So the key focus areas, of course, are always prevention, 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 but not just prevention, because we're never going to prevent all cases. So we have to put efforts into thinking about how we can do a better job at emergency workup and care, access to neurosurgery, access to critical care and therapies for TBI that are better than the ones we have now, the need for rehabilitation, and then very importantly, we're not going to make any progress in these areas without public and political engagement. So these are the two biggest programs in neurotrauma research, based out of the US and in Europe, respectively, Track TBI and Center TBI. Magnificent programs, a huge amount of money that have been thrown at those programs, and they have been incredibly productive. The problem, of course, is that the burden of disease is not predominantly in the US and in Western Europe, just in terms of the absolute numbers. And the question is, how do we take that kind of effort, that kind of organization, and apply it to where the disease is actually happening? And so that's primarily why we need global collaboration. And Professor Peter Hutchinson is going to tell you exactly how we've gone about doing it in the context of this group. Thank you.
Thank you so much, Professor Figaji, for this wonderful presentation. So we're just going to take Professor Huge. Hi, Professor Huge.
Thank you, Tony, for setting the scene and everything, Tony, that you do in terms of the acquired brain and spine injury group. So I co-direct the group with Tony. It is called the NIHR Global Health Research Group on Acquired Brain and Spine Injuries. On the 15th of November 2022, the world's population exceeded 8 billion people. That was a very defining day. And the Global Surgery 2030
Sorry, Professor Hutch, your voice is low.
Sorry?
Your voice is low, Professor Hutch.
Can you hear me now?
Yes, Professor.
So Global Surgery 2030 showed that of these 8 billion people on the planet, that 5 billion do not have access to what is defined as life-saving or disability-preventing treatment, i.e. surgical care. If you look at neurosurgery specifically, can you hear me now?
We can hear you, Prof. I don't know if the problem is specific to me, but I can't see your screen. I don't know if it's the same with others.
It's the same for me. Brandon, could
Screen
you
also not
help?
visible.
It does say it's screen sharing.
Yeah, it's strange. You can only see the top bar. I definitely want to try restart the screen share.
Yeah, can do that.
Yeah, now we can see. Thank you.
It's good, Prof.
Okay now. It's okay now?
Yes, it's okay, Professor.
Okay. So I just wanted to thank Tony in terms of our collaboration and co-directing the NIHR Global Health Research Group on Acquired Brain and Spine Injuries. As I said, the population of the planet reached 8 billion people in November 2022, and 5 billion of these do not have access to surgical care. In neurosurgery specifically, there are now approximately 50,000 neurosurgeons globally. 33 countries have no neurosurgeons at all, and it's felt that we need 23,000 additional neurosurgeons to address the 5 million essential neurosurgical cases that are unmet. And Tony's already alluded to this, all of these cases are in low middle income countries. So the background of the NIHR Research Group on Acquired Brain and Spine Injury, this came out of the previous group, which focused slowly on neurotrauma, but now we're also including traumatic spine injury, stroke, brain infections, and CSF fluid disorders, hydrocephalus. Tony's already discussed this, but trauma does kill an astonishing number of patients per day, about 11,000, and a major proportion of these are dying as a result of traumatic brain injury. 90% are occurring in low-income countries, 90% of research is undertaken in high-income countries. And just again, huge credit to Tony and the African Brainchild Initiative. I'll come back to that. So we know that the deficiencies in care relate to delays in surgery, lack of access to what we would deem as really important investigation, CT scanning, intensive care, ICP monitoring rehabilitation. And if you look at the proportion of patients discharged to a rehabilitation facility in Europe compared to India, there are very marked differences. The group itself is arranged across 4 themes: mapping care, understanding care, novel innovation, and capacity building. And I'd just like to thank Charlie Whiffen in particular for the work that she's done, particularly in terms of qualitative research and capacity building in theme 4. The biggest output that's come out of theme 1 is the GENOS study. So this was a study looking at the case management of mortality of patients receiving emergency neurosurgery for traumatic brain injury. And I think what this study illustrated was the changing demography of traumatic brain injury across the planet, where this is now, in high-income countries, a disease of more elderly people who are falling, usually from their own height, whereas in low middle-income countries, this is now a real pandemic of injuries and death that are caused from road traffic collision, and that's something that needs urgently addressing. Working with Tom Bashford, theme 2 is looking at systems engineering and how we can apply and model a systems engineering approach to these patients to model current care pathways and the impact of what a change should be, and then the effect of that change, which would be a very efficient way of improving care pathways. So that's led by Tom Bashford, and Brandon Smith's been a really important part of that too. I've already alluded about problems with access to CT. Are there other ways by which we can diagnose brain injury? So the infra scanner can detect blood clots within 3 centimeters of the surface. That's something that the group is currently investigating in Colombia, Guatemala, and parts of India. We're looking at more cost-effective mechanism of follow-up using SMS text message, such as through mobile phones. And then we have an initiative in Malaysia where we can use telemedicine through smart glasses to help improve management of patients in rural areas. And finally, looking at long-term data collection through rehabilitation using families. And then Charlie's very much been involved in this research capacity building, capacity output and training, mapping the current research output. Training is really important. So Ricky Trivedi, colleague of mine in Cambridge, has been working with Kajinja Seja in Zambia, running neurotrauma courses, growing capacity in Zambia from 2 to 8 neurosurgeons, building research capacity such that the largest recruiter in the rescue acute subdural RCT was actually Bangalore. Really grateful for that. And then working with other organizations to strengthen a research output. Tony's already talked a little bit about publishing and advocacy, but this needs to go beyond academic publishing and actually use data to advocate for the management of patients with neurosurgical conditions, and particularly traumatic brain injury. And lobbying through the G4 Alliance at the World Health Assembly is one way of doing that. Tony's already mentioned the plan to make neurotrauma a notifiable condition, and Almas is going to talk about that shortly. But this is going to be absolutely essential if we're going to build capacity, get resource into the management of patients with head and traumatic brain injuries. We have to create the data, and to do that, we have to deem this as a notifiable condition. GENOS led on to the GeoTBI registry, so this now has well over 2,000 patients. If you're interested in entering the registry, the website is geotbi.org. This is a powerful registry because it can serve as a data platform for your own data to look at your own outcomes, but also contribute to a larger registry of patients globally to generate more data. And what we're hoping is that GeoTBI will become the data collection platform in order to designate this as a notifiable disease. The group works with other initiatives, including the Society of British Neurological Surgeons Global Neurosurgery Research Initiative. This now has a very active networking program between UK and Irish units and units elsewhere globally. And we're very grateful to Alistair Jenkins and the Diane and Alan Carter Fund for a generous donation to help the SBNS Global Initiative flourish. We work with the CNS and the Red Journal, led by Gail Rousseau, in terms of the Global Neurosurgery section, which is a good forum for publishing our work. And we work through the Royal College of Surgeons and the London School of Economics to look at how we can go beyond pure clinical outcomes, but actually a real focus on health economics in order to help generate capacity building as well as the actual clinical data, we have to look at health economics and the cost of treating these patients, how that varies across countries, and how we can provide more cost-effective management. So in summary, what have the group been doing to reduce neurosurgical disparities? Prevention, so advocating for helmets, motorcycle helmets in ELMIC, cycle helmets in high-income countries, and Tony's amazing campaign that Tony and Devon lead in Cape Town on recycling car seats across Africa has probably been one of the most impactful activities of the group. We've looked at pathways of care through a systems engineering approach. We've shown that we can deliver randomized trials and change practice, working globally, again, a partnership with NIMHANS in Bangalore. But we also need to look beyond academic publishing, consensus meetings, getting into guidelines, following traumatic brain injury to actually change surgical practice. We know that rehabilitation is very challenging, so we have initiatives where we can actually teach families to deliver rehabilitation. I've already talked about the GOTBI registry. This is endorsed and supported by the WFNS, and we need to look at continuing development of technology that's cost-effective, easily accessible to improve the investigation and diagnosis of patients with neurosurgical conditions globally. We've been fortunate with the group, and credit to all members of the group for capacity building. There are now neurotrauma researchers in the group based in 12 countries with substantial research output, but more importantly, training the next generation of research leaders in low and middle income countries. Policy, already talked about the concept of neurotrauma as a notifiable disease, but we need to continue to lobby for that. And beyond that, developing leadership, working with international partners, professional organizations to provide global leadership has to be the way forward. And that also includes engagement in training and clinical mentorship. So to conclude, we know, and Tony's already discussed this, that the issues of improving prevention, advancing care, and stimulating research in ELMIC countries is huge. It's also an ongoing issue in high-income countries. So globally, current efforts should be strengthened and new efforts should be developed. This is a two-way process. We can all learn from each other. A much global interaction of different countries with different ways of managing people, different strategies. We can learn from each other. And many of the strategies that have been applied in other countries have now been implemented in the UK. And finally, what's really important is that this group publishes, but it is no good just producing research for the sake of research. We have to make sure we have a duty to ensure that research transforms into policy, changing practice, improving outcomes for patients. So I'd like to thank our collaborators and partners across the world, particularly Tony and the group in Cape Town for leading this with us as a joint collaboration, many other universities and hospitals. Tony's already shown the photograph of the current group. That was the previous group on the top that was meeting in Robinson College when we started this initiative in 2017. A word of caution, the group is going well, but I think what we need to make sure is that the group continues. You'll be aware that there is pressure on global health funding across a number of nations at the moment. So we really need to double down and keep our efforts going in order to help advance the knowledge of this condition and improve care for the management of patients. Thank you.